In Part 2, we will review common cardiopulmonary pathologies to include pulmonary edema, chronic bronchitis, bronchiectasis, emphysema, idiopathic pulmonary fibrosis, pneumothorax, atelectasis, pneumonia, coronary artery disease, and chronic heart failure. Pulmonary edema is a result of blood backflow and increased capillary pressure in the lungs. The most common cause of pulmonary edema is left heart failure. These image findings demonstrate patchy infiltrates as noted on the radiograph. The severity is determined by the superior progression of these infiltrates. Note there is very little room for the air in these lungs in the upper portions. This patient has extensive disease and would not be appropriate for physical therapy. Both the current weight and the dry weight, as well as the extensiveness seen on the image, would guide appropriateness for treatment. Your clinical patients will be patients presenting with orthopnea. This is measured in pillows because laying flat causes increased capillary pressure, so the person needs to be propped up by pillows and is unable to tolerate the supine position. Auscultation is also identified with fine crackles at the base, which works up distal to proximal. Chronic bronchitis is defined as a cough that occurs daily with sputum production that lasts for at least 3 months, 2 years in a row. The inflammation, swelling, and mucus frequently and significantly inhibit the airflow to and from the alveoli by narrowing and partially obstructing the bronchi and bronchioles. Image 1 shows more prominent bronchioles markings evident by the increased spider-like appearance. The hyperinflation of the lungs is noted by the flattening of the diaphragm in image 2, as well as the flattening of the lateral chest wall. These are hallmark signs of any obstructive disease, chronic bronchitis being the most common. In both images 2 and 3, we can see mucus plubs as radiodense clusters in the bronchioles. For physical therapists looking at this would indicate the need for airway clearance. Bronchiectasis is a form of COPD which also includes emphysema and chronic bronchitis. This causes thickening of the airways and dilation. Imaging findings on the axial CT scan, we see thickening of the airways, and they're more dilated, so they're more prominent, allowing the air to try to flow through. We also see some plugging of these airways. PT implications when visualizing these images helps to determine the extensiveness of the mucus plugging, guiding the prescription for frequency of airway clearance. Emphysema, another chronic obstructive pulmonary disease, occurs when the air sacs in the lungs are gradually destroyed. These airways collapse on exhalation, trapping air. A chest radiograph can help confirm a diagnosis of advanced emphysema and rule out other causes of shortness of breath. Image 1, we see lucent areas or holes. This is a Swiss cheese appearance. For accurate diagnosis, a CT scan is ordered to indicate the trapping of air within the alveolar. Visualization of these images will indicate the severity and guide positioning for optimal ventilation perfusion. Idiopathic pulmonary fibrosis, or IPF, is a disease in which small airways or alveoli in the lungs become thick and stiff or scarred over time. The formation of scar tissue is called fibrosis. This decreases the oxygenation in the bloodstream. IPF is a serious disease that usually affects middle-aged and older adults with a 2 to 3 year lifespan from diagnosis. Image 1 is a PA radiograph that demonstrates the diffuse scarring. The amount denotes the severity. Note the difference in the image appearance from the small airways disease compared to the previously seen images for the large airway pathology. Image 2 is a CT scan of the right anterior lung. We note a honeycomb appearance. This is a hallmark sign of IPF. As PTs visualizing these images, we can observe the severity of the disease and the specificity. If there is a more localized area affected, physical therapists can position the patients for maximal ventilation perfusion matching. In this case, it would be laying the patient on their left side to assist in improved oxygenation. A pneumothorax is the absence of lung tissue seen on an image as a lucency or hypodensity. We can see this one clearly at the costophrenic angle. Patient presents with acutely short of breath, pain in the area, and poor gas exchange, which will result in low oxygenation or O2 saturation. For physical therapy, the implication is to know that treatment is usually a chest tube, but identifying the localized areas again can assist in positioning for maximal ventilation perfusion matching. Atelectasis is collapsing of the alveoli. This is a normal occurrence with inactivity and post-surgical, but it could also be a precursor to pneumonia. The image findings on image 1 show the right upper lobe atelectasis noticed by the opacity. In image 2, we see more of a plate-like atelectasis or a glass appearance. The implications again are seeing this on radiographs as an indication for deep breathing exercises or the use of the incentive spirometer and to maximize patients' functional mobility. Pneumonia is an infection of the lung. In image 1, we see the pneumonia noted by the patchy infiltrate on the right middle lobe. Image 2 is more of a basilar lower lobe or right lower lobe. With the image 2, we have both the PA and the lateral to help us better localize the infection. Again, understanding this localization will help with positioning for maximal ventilation perfusion matching, and the need for airway clearance will be evident by visualizing these images. Advanced imaging for cardiac disease can include CT scans. Here we see an axial CT scan of the heart that determines the presence of calcification, as seen by the hypodensities. This is clearly demonstrating the calcium deposits or plaques that's consistent with coronary artery disease. This technique has become more common in the last few years. As PTs, it is noted when ambulating and maximizing function in your patients, you would closely monitor vital signs and symptoms for angina with the presence of coronary artery disease. Heart failure can first be noted on radiograph. You would note in a large heart shadow greater than 50% of the lung diameter. Further imaging is indicated to identify the extent of heart failure. An echocardiogram report will identify the left ventricular ejection fracture. Image 1 is a PA chest radiograph demonstrating cardiomegaly. Image 2 is an echocardiogram of a normal heart. Notice how the left ventricle is clear and full of blood. And image 3 is a cardiogram with a thickened left ventricular wall and decreased blood. This is a sign of heart failure. The ejection fracture is an important indicator for the severity of the disease and guide your treatment. In this two-part presentation, we reviewed routine radiographs, indications for additional studies, evidence-based guidelines, and common pathologies. Clinicians should incorporate information from imaging into patient management, but should never rely on imaging diagnosis alone.